Thank you for joining us for Lies, Damn Lies, and Research Design, sorting out facts from fake facts. This is the first webinar for the CTN Community Advisory Committee to help build capacity in research design. I'd like to introduce Dr. Joel Singer, Program Head, Methodology and Statistics at the CTN and a professor at UBC. Over to Joel.
So I have no conflicts of interest, and in terms of plagiarism, I have paraphrased a few authors and borrowed a few slides. I'll start by referring to yet another American politician who talked about known unknowns and unknown unknowns. So over my personal history as a research methodologist, I often do research consultations. I've done hundreds of them, and people, when they walk in, they're even quite proud to say they know nothing about numbers and statistics. But it seems that people often think they know about design, and even the best statistics can't rescue poor design. So I refer to design as an unknown unknown, and I'll be talking about issues primarily in design. The one thing that I did want to say about statistics is that there really is a difference between the manipulation of numbers, which statisticians do, and I don't necessarily expect people to know about those things. But the logic of statistics is something else, and sometimes we even get statisticians right out of training who can manipulate the numbers but really don't understand the logic of statistics. And really, for in terms of what the Community Advisory Committee does and what they need to know, really for the comparison of treatments, what you need to understand is that we're evaluating whether observed differences that we see in two different treatment groups are so great they're unlikely to have occurred by chance if the treatments are really equivalent to one another. So essentially what we're trying to understand is whether those differences that we observe are likely due to the difference between treatments as opposed to simply occurring by chance alone. The research objective that we're trying to understand is whether we can get a valid answer to a relevant question in an ethical and efficient manner. And what I'm going to focus on is the validity of how we ask and answer the question, and also about the relevance of the question. And again, that will it will pertain to the way the research question is actually designed. So what I see as the learning objectives for this webinar is to make sure that you understand the primary biases and limitations of different research designs for the comparative evaluation of therapies, to understand how the study entry criteria can affect the internal validity, that is, the fairness of the comparison of the two treatments, that is not biased in favor of one treatment or the other, and the real-world applicability of the results of a trial. And again, this will refer back to the way the trial has been designed. And finally, I want to make sure that you recognize basic research terms and understand basic principles and the significance of them. In terms of the content of this webinar, I'll start with a slide that I've borrowed from the Institute of Medicine. This is a slide from about 5 years ago. In this slide, in this pie chart, you can see what we actually know about the most common treatments. So they looked at the effectiveness of 3,000 treatments as reported in RCTs selected by the amount of clinical evidence. And you can see the biggest part of this pie, the gray part on the left-hand side, shows you treatments that are used where there really is unknown effectiveness. So about half of the most common treatments have unknown effectiveness. So they haven't really been properly evaluated. And you might wonder, how is it possible that half of the treatments that we use really don't have proper studies underlying them? As you probably know, for a new treatment to be approved, it has to undergo very strict regulatory oversight. So again, you might wonder, how is it that 50% of treatments that are used really don't have that? And the answer is that for a new treatment to be approved, it's approved for a particular labeling. But as often happens in trials, people will notice that drugs may have other unintended beneficial effects. So for instance, with some of the antiretroviral drugs, it was noted that patients with those drugs had lowered cholesterol. So people may start to use these drugs for these unintended consequences, and it's not necessary for pharmaceutical companies to actually do trials to show these benefits. If a physician wants to use these drugs for these unintended benefits, they're free to do so. And so often it's left to public funding agencies to fund studies to ascertain whether these drugs are really effective for these unintended effects which are not labeled. And there's often not a great incentive for pharmaceutical companies to actually do that sort of research. So this has led to people talking about comparative effectiveness research, because the truth of the matter is there's no way that public funding agencies have the money to actually evaluate all of these other things that drugs are actually labeled for. So often what we're left with is evaluating these other effects with observational designs. And that's simply because RCTs are very expensive, and there's really not money from public funding companies to actually allow RCTs to go forward to evaluate these things. So we're looking for other methods, and as I mentioned before, usually through observational trials, that we can evaluate one treatment versus the other. And again, when you think about the work of the Canadian HIV Trials Network, we're devoted mainly to clinical trials, but we also support observational cohorts. And so what I'm going to do in this talk is talk primarily about RCTs, but also contrast them with other sorts of designs, observational designs, and let you know what some of the problems that you have to be aware of with observational designs. So I'm going to continue by giving you a simple example of bias. So let's say we take two groups with disease X, and you treat the first group that contains primarily less sick patients with treatment 1, and a second group that has primarily more sick patients with treatment 2. And now we go ahead and examine the outcomes after some time and find that those on treatment 1 have better outcomes than those on treatment 2. And the dilemma here is we don't know whether treatment 1 had better outcomes than treatment 2 because the patients who received treatment 1 were less sick to begin with than the patients in treatment 2. So we don't know whether it has to do with the patients and differences among the patient groups to begin with, or whether it's actually the differential effect of the treatment, or it might be both. It might be that one group started out better than the other, and there's also a treatment effect. But what this is an example of is confounding. And what confounding refers to is the situation where treatment groups differ at baseline on some characteristic that's known to be associated with the outcome that you're studying. So a good example of this in HIV is groups differing on CD4 at baseline. And of course now most patients, even patients with low CD4s, can be prevented from progressing to AIDS and mortality because we have such effective treatments. But earlier on in the era of HIV experimentation, this is something that we really had to worry about. And if one group started out at higher CD4 than the second treatment group, you might expect that they would show less progression to AIDS and death. So what's the resolution to this problem? Well, first of all, we want to minimize the chance that patients in comparative groups differ in prognosis. And as I'll be explaining, the way to do this is to both randomize and stratify the randomization, and we'll explain this in more detail as I go along. We want to ensure that patients are treated and then evaluated identically except for the treatments under evaluation. So the way to do this is to blind the study if possible. And lastly, we want to ensure that analytic strategies do not bias the comparison, and we'll be discussing the principle of intention to treat. So I'm going to start with a little bit of historical perspective. The first randomized trial that was ever reported was in the BMJ in the October 30th, 1948 issue, and it was a trial of pulmonary TB, examining the effect of streptomycin versus a placebo. And remarkably, this was the first randomized trial. And the way it differed from previous trials is that the allocation, rather than being self-selected where physicians and patients chose their therapy, now patients were allocated to a treatment or a control group via a random process. Now, interestingly enough, I was fortunate enough to go to the second Sackett Symposium. This was in honor of Dave Sackett, who was a popularizer of the RCT both within Canada and globally. And ironically, the title of the symposium was, "Is it time to retire the RCT?" This symposium took place in 2013. The RCT was 65 years old at the time, and I would note that mandatory retirement age was abolished around 2008 in BC. We're not quite as progressive as other provinces in Canada. The first province to ban mandatory retirement was Quebec in 1982. So with that said, we'll come back to what the conclusions of that symposium were. And I would note that the majority of speakers at this symposium were experts in different types of observational designs to evaluate the comparative effectiveness of treatments. So I'll start with some schematics. So in this first slide, you see the experimental hierarchy in a randomized controlled trial. So we have a reference population, and that's the population to which you want to be able to generalize the results. Now, typically in a randomized trial, we're not randomly sampling from that population. The study population is typically drawn from patients in certain geographical areas, and if it's a hospital-based study, it will be done at certain hospitals, and typically these are hospitals that are associated with medical schools, so usually tertiary care institutions, although there are trials that are done out of physicians' offices or more general hospitals, but generally it's not a random sample of the population. So where does the random and randomized control trial come from? Well, it doesn't even come at the level of the geographic areas where the trial has taken place, because once you identify those, you actually have to get informed consent for people to participate. So you're going to get non-participants, people who don't care to volunteer, and you have participants those who do volunteer. And obviously, if that's a high proportion, if the participants are a high proportion of those approached, again, you feel more comfortable that the results may be generalizable. But the random component in randomized controlled trials happens in the allocation process. So once people agree to participate, they're then assigned by randomization to a study group or a control group. And of course, you may have studies that have multiple groups. So again, what is not random is the selection of participants or the selection of treatments, and what is random is the allocation of participants. And the advantages of a randomized trial is that, first of all, it eliminates self-selection bias. So individual participants and their caregivers are not deciding on the treatment. It's selected in a random way. And by this way, in this manner, you get internal validity. In other words, you tend to get treatment groups which are fairly well balanced, and therefore the comparison of outcomes is internally valid within the study. In smaller studies, there's a greater chance that you may have imbalance in the treatment groups, but certainly in large studies, the chances that there are going to be major imbalances in the treatment groups is very, very low. The other advantage of randomized studies is that you get very careful control, both in the evaluation and reporting of outcomes. So people are adhering to a particular protocol. There's all sorts of checks and balances on the data that is reported. And again, if this is a drug study, blinding becomes possible, both of the participants, the clinicians involved, and also those who are evaluating the outcome, who may be different from the participants and the clinicians who are administering the treatments. The disadvantage is that randomized trials are often not real world. In other words, they're very contrived, very controlled circumstances. Maybe it's using the optimal patients or participants, in the sense that we pre-selected participants who are likely to be compliant. We may choose the best clinician. So if it's some sort of intervention that requires expertise, maybe we're choosing only the best clinicians. And of course, the cost of trials is very, very high. Now, the contrast with that is the observational study. And one type of observational study actually uses linked databases. And actually here in the province of British Columbia, we probably have the most extensively linked databases among all the Canadian provinces. So you can link hospital visits, doctor visits, laboratory evaluations, visits to physicians, and so forth. So you could actually have a situation where you look at people who received one treatment versus participants who received an alternative treatment, and compare their outcomes down the line. And of course, now we're dealing with a situation where people are assigned by self-selection to one group or another. Just to give you an example, I believe Aslam Anis, who's one of the network directors at one time, did an evaluation of people who were receiving one type of treatment, and these are people who had asthma, versus another type of treatment, and that was the comparison of interest, and he was using these linked databases. Now, the advantage of, particularly of this type of observational study, is that it really is real world. So we had every person in the province who was identified with this particular clinical diagnosis, and seeing a physician, obviously, and we were comparing them on these two treatments. And so it was a real world in terms of how the patients were handled. It was obviously a representative sample, and the data is already there. It's in databases, so the cost of actually getting the data is minimal compared to a randomized controlled trial. The disadvantage, of course, is that, again, there's self-selection bias. The participants, the clinicians, are deciding what the participants are going to get. The recording may be poor. The recording may be biased, so the clinicians know what the participant got, and that might influence the way they make the diagnosis, they assess the outcome. And it's limited also by types of data. So, for instance, in clinical care, participants are not routinely filling out quality of life questionnaires. The other thing that I want to bring up in terms of the sort of self-selection bias that you get, a researcher at UBC showed that people often don't fill out their prescriptions, and the reason they don't fill out their prescriptions is they don't have coverage and they can't afford to fill them out. And of course, socioeconomic status is associated with many outcomes. So in this sort of situation, you would not be able to detect that. In other words, if a person doesn't fill out a prescription, they would go into the control group. And of course, this is going to bias the comparison. So that's the sort of bias that you can get in this sort of study. So I'll continue by giving you a clinical scenario and talk about a trial that was actually done, a randomized trial, to illustrate, again, the sort of biases that we worry about, not only in terms of how patients are randomized, but also in terms of how they're analyzed. So the clinical scenario that I'm going to talk about is, should I advise my female patients in a certain age range to have breast cancer screening? Now this trial that I'm referring to was done a long time ago, around in 1980. It was done in the United States, and it was done with one of these health service organizations, so they have this large patient population. And the intervention was physical exam plus mammography. Well, that was part of the intervention. The true intervention was the offer of screening. So this was designed as a randomized controlled trial. There were 62,000 women of this particular age category and meeting other eligibility criteria in this study. And they sent out invitations to 31,000 women to come for screening, and the other 31,000 continued their usual care. Now, the first result was that only 65% of those who were invited to attend screening actually came. And now let's look at, in the lower part of this slide, at the incidence of breast cancer. And right now we're focusing only on those women in the invited arm, but we're breaking them down by those invited women who did not go to screening and those invited women who did go to screening. So you can see that the invited women who did not go to screening actually had a much lower rate of breast cancer than those who did go to screening. And you might be wondering, well, isn't that counterintuitive? If screening is supposed to provide benefits, why is the rate of breast cancer higher in those women who actually took advantage of the screening? So there's a couple of reasons why this may have occurred. So the first one is we may be picking up asymptomatic cases in the screen group. In other words, we're simply detecting these cases earlier on. But there's another thing that we really have to be concerned about, and that's that who decides to go to screening and who decides not to go to screening? Well, women who go to screening may be different than those who don't. And this is going to be based on things like family history of disease, different health habits, different socioeconomic status. So if a woman has a mother or a sister who had breast cancer, that may predispose her to going to screening. And if she doesn't have family members who've had breast cancer, that may predispose her to not going to screening. So when we compare those two groups, we have to understand that the women who didn't go to screening are likely less at risk. So we're not comparing apples to apples, we're comparing apples to oranges. And here we see the results in the usual care group who did not receive screening, and the invited women who did not go to screening. So essentially, those two groups received the same treatment. In usual care, it's unselected, so it includes all women who were not invited to screening and they didn't go to screening. And you can see their rate of outcome, their rate of breast cancer is actually higher than invited women who did not go to screening. Now, both those groups got the same treatment, and you might expect, well, they should have equivalent outcome rates. And again, the reason that the outcome rate is higher in the usual care group is that it includes the whole gamut of women. It includes high-risk women, low-risk women, medium-risk women, whereas the invited women who did not go to screening likely include predominantly lower-risk women. In other words, if women who did have family history likely went to screening and would not be included in that group. So this is a way that bias can creep in to an analysis if we excluded women who actually didn't receive the intervention. So again, intuitively, you think, oh, why should we include people who didn't include the intervention? But you have to remember that the reason we randomize is to create groups that have balance. And once you start excluding people from the analysis, it's very possible that you're introducing bias. So again, the lesson that we learn here is that self-selection bias can create unequal groups and biased comparisons. In RCTs, although it would seem to make intuitive sense to exclude from analysis study participants not receiving therapy, this can create a strong opportunity for bias. So what we tend to do in randomized trials is analyze all those randomized. In other words, we use this intention to treat principle. So as soon as you randomize to treatment 1 or treatment 2, we analyze your outcome and we attribute it to the group that you were attributed to, whether you actually got the treatment or not. And by and large, this may give you a conservative estimate of the treatment effect, but we'd rather have that than introduce a new treatment based on a biased comparison which favors the experimental treatment. And the other thing that you have to remember is that poor compliance and dropout actually mimics what happens in the real world. So we don't expect in the real clinical world patients to be 100% compliant. And if some patients are not compliant or drop out of therapy for personal reasons, that mimics what's actually going to happen in the real world. So again, the solutions are to randomize, to stratify, and to blind, and I'll talk about these issues now. So again, I expect that you all know what randomization is. It's allocation of groups by a random mechanism. And the reason that we do it is, first of all, to eliminate selection bias. It tends to create groups that are comparable, both on factors that are known and or unknown that may influence response. So just to give you an example, in the early history of HIV studies, we didn't have HIV RNA testing available yet, but clever investigators maintained blood samples and put them in freezers from baseline valuation. And by the end of the study, people had developed assays to ascertain the amount of virus in blood. And again, randomization did its magic work. And when they looked at the HIV RNA in the experimental and control groups, by and large, they were balanced on HIV RNA, even though HIV RNA was something that couldn't be measured at baseline. the randomization is also the basis for statistical inference. In other words, we're assuming that we start out with groups that are relatively well balanced, and that's achieved by randomization. If you start out with biased groups, statistical inference does not. The statistics can lead you to a false conclusion unless you do something to try and balance for that initial imbalance, and we'll talk about that a little bit later on. And randomization is also the necessary condition for blinding. In other words, obviously, if people know what they're on, you can't blind them. So if you randomize, you can make sure that nobody who's associated with the trial knows what treatment they're on. And of course, you can only do this with certain sorts of interventions like drugs. What I'm referring to when I talk about stratification or stratified randomization is ensuring that the randomization is balanced for certain sort of characteristics. So, for instance, if we know that patients with high CD4s tend to do better than patients with low CD4s, we can then say, okay, anybody with a CD4 greater than 500, we'll make sure that there are equal numbers of those in the two treatment groups, and we'll make sure also that participants with low CD4s are also equally divided between the two groups. So you have balance between the groups on factors that you know are most important. So again, the advantage of stratifying is it guarantees balance between treatment groups with respect to the factor that you're stratifying on. And stratification is less important if a trial is very large. And the way that you can think about this is if we had a coin and a fair coin and we flipped it 10 times, it's possible you could come up with 9 heads and 1 tail. But if you flip that coin 1,000 times, you're never going to come up with 900 heads and 100 tails, like 90%, 10%. So as the trial gets larger and larger, the chance that you're going to have imbalance on any important baseline factor decreases. If the chance of a stratification error is high, then you might tend not to balance on it. So again, there might be some factors that we believe are important in predicting outcome, but there might be a lot of variation in the measurement of that factor from today to tomorrow or today to next week. So probably not a great basis for dividing the sample. And also there might be certain situations in which we're very uncertain about which characteristics influence outcomes, so it doesn't really make sense to stratify in that sort of situation. Now, there might be situations in which you come to the end of a trial and there is some imbalance of important factors. It's really not, I'm not going to go into the reasons for it, but it's really not possible to balance on many baseline factors simultaneously. So let's say you stratify in the first on the two most important factors, you still might by chance have imbalance on another factor that you believe to be important. And statisticians have figured out ways that you can actually balance for important factors. In other words, correct for imbalances when it comes to analysis. And I'll talk a very little bit about that as we go on. And the last thing that I wanted to talk about as a mechanism for controlling imbalance between groups, and this is more at the stage of how patients are treated within the trial and how patients are evaluated, is in terms of actual blinding. So making sure that the participants, the investigators, and the evaluators are not aware of treatment value, of group allocation. So of course, when we talk about single blind, it could be the participant or the investigator who are blinded. When we talk about double blind, typically we're talking about the participant and the investigator. And when we talk about triple blind, we're talking about all three of those people. And often there's situations where you can't blind the allocation because we're talking about, say, something like a surgical intervention. But even in those cases, you can usually blind the evaluator, as long as it's the person who's doing the evaluation doesn't know what the participant has received. And again, this manipulation is designed to induce comparability in the handling and evaluation of patients. In other words, avoid bias due to the knowledge of treatment, and it preserves integrity of the randomization. In other words, when in situations where both physicians and participants know what the participant's receiving, this may predispose switching of treatments or dropout, and we want to prevent that from happening. So again, what are the potential consequences of not blinding? Assignment may be biased consciously or unconsciously in favor of one of the treatments. In other words, if the person doing the allocation actually knew what the next randomization was, they could say, oh, well, I know this person's getting the experimental treatment, they're really sick, so we're going to randomize the sickest patients who are unlikely to benefit from treatment to the control group. And of course, this would induce a bias. Healthcare providers may treat experimental and control participants differently. So in other words, if they know a participant's getting the control treatment, they may try to supplement other treatments that they're getting aside from the control treatment. And they might also do more diagnostic tests on control participants because they're worried that they may progress more quickly. Participants may be more likely to withdraw from therapy if they know they're in the control arm. So they might think, oh, well, I can get the control arm outside of a trial anyway, so why should I bother? And may predispose them to withdraw. Participants may be more likely to report side effects if they know they're on an active medication or a specific active medication. For subjective outcomes like pain or symptoms, participants may alter their assessment if they know which treatment they're receiving. So again, they know they're on the experimental treatment. This might induce an expectancy that they're going to have less pain, less symptoms, and that biases their assessment. And also, knowledge of treatment may alter the evaluation of outcome. So even things like reading of ECGs, reading of X-rays, if the evaluator knows that a participant was receiving the experimental treatment, that may alter the evaluation in cases where it's difficult to say whether or not the person had an outcome or not. So there's a question. What do we do in situations where we have to have non-blinded studies? And I don't want to leave anybody with the impression that, oh, if it's a non-blinded study, you should just ignore it. But in cases where we have non-blinded studies, there have to be careful assessments about whether the lack of blinding may have led to bias. So what are sorts of things that you might look for? So was there more co-intervention? In other words, use of other treatments other than the study treatments in one arm versus the other arm? Was there contamination? In other words, did people in the control arm somehow get access to the experimental treatment outside the study? Was the assessment of outcome unbiased? And again, in most situations, you can do things like you can have the evaluator be unbiased. Now, unfortunately, there may be studies which can't be blinded, and the evaluator can't be blinded either. So it might be a situation where the most important outcome is something like a symptom or pain, and then that requires a subjective evaluation from a patient or a participant. And in that sort of situation, they might be influenced by the knowledge of what treatment they received. So there's no easy menu for the way of preventing bias in situations like this. But sometimes what you can do is run some other test which is more objective alongside the more subjective test and see if the results are parallel. Now another question is whether trials should always be blinded when they can be. And so the issue here is whether, what's more important, a fair comparison within the trial, which you can get, you're more likely to get when you blind, versus generalizability to the real world. So I can give you an example where we had to make a decision like this in a CTN trial. So this goes back way back to I think 1993 or 1994, where we were comparing two alternative multi-drug regimens for Mycobacterium avium complex, and this is a late-stage complication of HIV. And the problem was we were comparing a 3-drug regimen to a 4-drug regimen. Well, there's multiple complications here. If you actually provided placebos, now you would have patients taking 6 or 7 drugs, and you can imagine what that would do to compliance. It would drive it way down. So if you force people to be blinded and take placebos in addition to their actual medications, you would probably be driving down compliance compared to where it would be in the real world, depressing actually the effectiveness of the treatment. As well, in terms of the way you would actually deal with patients having complications that are related to treatment, it would be a nightmare. So somebody has an adverse effect, and now you don't know which of 6 drugs or 7 drugs that it might be related to, as opposed to just being in the situation where you have 3 drugs where you have to decide which might be contributing to it. So again, in this sort of situation, we decided, even though blinding gives a more fair comparison, and in fact, one of the primary outcomes was a subjective outcome of quality of life evaluation, we decided that it just wasn't practical to have full blinding. And fortunately, in this situation, we were able to have a secondary outcome, which was a laboratory outcome, which was objective, and the results of the objective outcome paralleled the results of the quality of life outcome. So I just want to give you sort of an overview of the sorts of the primary sorts of things that we look at when we're evaluating a protocol. So the first thing is the population or patient issue. Who's the patient? What's the disease? Making sure that that matches what you think the patient population ought to be. And this will include all of the eligibility characteristics, so inclusion, exclusion criteria. What's the intervention that's being evaluated? What exactly is happening to the participant? What are the specific tests being done, the therapies, the medications being used? How well is that described? What is the comparator? What's the alternative to the experimental medication? I mean, it could be no treatment, in other words, a placebo. It could be a different type of treatment. And one of the things that we're always beware of, that it's always important to be aware of, is the fact that sometimes people choose an alternative treatment which isn't the best standard alternative. And of course that's biasing things to make the new experimental treatment look better than the comparator. The other issues are the outcome. What outcome are you looking to evaluate? Is it the most relevant outcome, the one that would be most relevant to the participant? And sometimes you have to understand that that the most relevant outcome might not be chosen as the primary outcome simply because it's not feasible. In other words, the trial would have to run too long or require too many participants in order to evaluate that. And that's particularly a problem when you're looking at people who have at an early stage of a disease. So it may be a long time until they develop clinical manifestations of the disease. So then you're looking at things like laboratory markers, which might be an early indicator of progression of disease. And of course, the time, what is the time frame? And again, this is really important because you might feel that the time frame is not adequate, in other words, not long enough to really be measuring the outcomes that you're most concerned about. The other aspect of trials that is very important to be aware of is this pragmatic or real world versus explanatory trial continuum. And I've listed different aspects of this, of these characteristics by the Picot hierarchy. So you can see eligibility criteria, the flexibility of the experimental intervention, and so on. And so basically what in a pragmatic or real world trial, you'd want it to take as many or to be as broad as possible. So in terms of eligibility criteria, you'd want it to be sort of all comers who have the disease. And again, you might want to limit that to some extent. And there's some eligibility criteria which of course are mandatory. Of course you have to have informed consent, and of course you can't include people who would be at high risk from a particular treatment. But other characteristics, you might be very broad or very, very narrow. And of course, the narrower the criteria that you use, the more limited the generalizability of the study are going to be. And just to give you another example, the experimental practitioner expertise. So, for instance, if you were evaluating a trial of surgery and you restricted it to the best surgical centers in Canada and the United States, that would have limited generalizability to the broad population. And it's not as if one is right and the other is wrong. It might also depend on where you are in terms of your knowledge of the population or the knowledge of the intervention. And so, the first trial you might do, you might want to choose a very narrow population under very controlled circumstances. And this is so you get an idea of, well, if it doesn't work in this population, it's probably not going to work in the broader population. The big problem with this in terms of the study of drugs is often pharmaceutical companies will choose very narrow circumstances, and then they'll find an effect, they'll get the drug approved, and they'll never go on to do the study with the more real-world population. And that's left to public funders to do, and often there's a restriction in terms of the amount of money available. So just going to talk a little bit about what I see as the major RCT issues. So number one is, how do the entry criteria limit the extent to which the study may be generalized, and is it better to make the criteria broad or narrow, pragmatic versus explanatory trials? And in terms of that, I've explained what some of the advantages of going one way or the other are. I just want to give you a couple of examples of situations where the choice of what the entry criteria were would have had a dramatic effect on how the trial was interpreted and implemented. So the first trial I was ever involved in as an investigator was a trial of aspirin ASA in cardiac patients, and the primary outcome was MI or death. And so there were a couple of really major questions. We had to decide whether to restrict other drugs. So for instance, at that time, beta blockers were already on the market, but they hadn't been shown to be beneficial for these sorts of patients. But there was a trial actually ongoing. There was also the issue of whether patients in these sorts of trials should be allowed to have elective bypass surgery. And so the issue here was there were events that were associated with elective surgery, like a few patients might die. The mortality rate was really low, but a fair number of patients would have MI in association with the surgery. And so, in a sense, that would create noise that would be, it would be harder to see a signal in the difference between the treatment groups. And there were two trials going on, one in Canada and one in the US. And we decided to make our trial very broad, so we allowed the use of beta blockers, we allowed elective surgery, whereas the American trial didn't allow either. And as it happened, both trials showed a positive effect of aspirin, but I always wondered to myself, to what extent would aspirin have been adopted if it had been in a very restricted trial? In other words, if it had been in a trial that didn't allow beta blockers and had not allowed elective surgery. I think people would have been much more reluctant to uptake the intervention. Another example that I wanted to give you was the use of AZT versus DDI. This was an early study in the network in participants already on AZT. So the question is here, who on AZT is going to volunteer for the study, and what is the potential bias? So people who are doing really well, they may not volunteer. And people who are doing not so well, in other words, they're having some adverse consequences of being on the drug, they may be encouraged to volunteer because they're not doing so well. So right away, you might get a bias in terms of the type of participant in this trial. And if the people who are doing really well aren't going to switch, that may bias the trial, this trial against AZT. So among other factors that you have to consider is the real world aspect of the trial. So you might see some trials that have adherence enhancement. So you do things that really couldn't be done in the real world. And again, you have to worry about the applicability of the study to the real world. Another thing that you have to worry about is, what is the smallest difference that's actually clinically important? And what is the trial powered, or how large is the sample size, and is it able to pick up small differences that are believed to be clinically important? Should the outcome of all patients be counted? In other words, should we use the intent to treat principle? Yeah. And so you want to make sure that it's clear how missing data, how dropouts and crossovers are going to be handled in the analysis. Are the outcomes that are proposed relevant, and are they valid? Do they really indicate progression of disease? How do we choose a primary outcome when there are multi-dimensional aspects to the outcome? So, often there are various things that we measure. We emphasize, methodologists emphasize, that there should be one outcome that's designated as most important, and this is for statistical reasons that I don't have time to get into here. And finally, we have to worry about whether the trial will still be relevant by the time it ends. And I've given you a reference here to a website that has all sorts of wonderful documents about things that you should look at in the evaluation of protocols in both the trials that are published in deciding on whether they're relevant. So we get back to the question. I'm going to quickly finish off. Do we always need an RCT as opposed to an observational trial? And there was an article published in the BMJ in 2003 that considered whether it was important to have a trial to evaluate parachute use to prevent death and major trauma related to gravitational challenge. And so one of the things they did is they did what we conventionally do when we decide, do we need an RCT? So first of all, they combed the literature and they were unable to find any RCTs of parachute intervention. They determined that the benefit of parachutes was based largely on anecdotal evidence. Third, they saw that the lack of a parachute was not associated with 100% mortality. And if you look at the Guinness Book of World Records, there's actually a person who survived a fall of more than 10,000 meters. And finally, the use of parachutes in itself is associated with morbidity and mortality. Occasionally, the parachute gets tangled up and the person has an untoward outcome. So they concluded that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. So again, the point they were making is, really, if one anticipates that the treatment effect might be gigantic, that it's very unlikely that bias would ensue, you can probably get away without doing an RCT. And finally, so the question, should the RCT be retired? And I'm not suggesting in that last slide that we should be doing away with the RCT. And one of the things that was clearly acknowledged in the symposium is that we have a much better understanding of bias, how studies can be biased. We have better statistical methods than were previously used for that deal with possible confounding in observational studies. An example of these are regression analysis, propensity matching, causal modeling. So we have fairly sophisticated ways that we can adjust for baseline imbalances between treatments, but all of them do make unverifiable assumptions. So it's good if that's the best that's feasible, and we know we don't have money to do RCTs in every sort of situation. So we do have a better appreciation of methodological innovations that we can do in observational trials. But it's probably true that the best observational trial is usually less good than the best RCT. But again, I want to emphasize, you can have an RCT that's not very good, and you can have an observational trial that's excellent. So just because it's an observational trial, it should not necessarily be dismissed. So I will end there.
Great. Thank you, Joel. We're running a little bit late. Maybe we could stick around for 5-10 minutes if there's any questions. Oh.
Hi, it's Sherry. Thanks everyone for attending, and thanks Joel for a really great presentation. I have a question about, I wrote it down, stratification.
Yeah.
So when you're doing stratification, does that apply to other factors like gender and race as well?
Well, it can. And
okay.
So often we have situations where, and again, this is really naive investigators. You don't typically see this in the network, but whenever you see epidemiological tables, they're typically broken down by age and sex and gender. And sometimes people think, oh, well, if I'm going to stratify for any factor in a trial, it should be those factors. But of course, those factors may not be related to outcome in the particular disease that's being studied. So even though they may be important factors in their conventional ways of reporting things epidemiologically, they don't necessarily have to be stratified for in a trial.
So I guess then the trick is figuring out which ones you need to do it in and which ones it doesn't make much difference.
Yeah, and
usually we're always
usually,
faced with that at the table.
yeah, so typically you're guided by the literature, and typically you know what are the most important and most prevalent prognostic factors. So for instance, you might have some prognostic factor which is very strong, like you're 10 times more likely to have outcome if you have that factor than if you don't. But if it happens in only 1 out of every 100 patients, then probably doesn't make much sense to balance for it. So you want something that's common and also highly predictive of outcome.
So I guess what we should be looking for then in stratification and those types of things is, has it been properly justified? Is that what we should be looking for?
Yes, although, okay, so what I would say is if the trial is large, and that's really any trial over 100 patients, you're very unlikely to get imbalance. So stratification is more important in small trials. So if you have a small trial, stratification is probably a good thing to do, and it should be justified. Why did you choose the balance on this factor as opposed to something else? But in a large trial, if they haven't stratified, it's not a problem.
Okay, thanks.
All right, any other questions? Okay, Sherry, did you want to say a few words to wrap us up?
No, not really, except to say again, thank you. I think that was really helpful. Sometimes we might need to take some of this back and digest it a little bit and may have some questions. Certainly see why the statistics people get the big bucks in the research grants, because it's really complicated. So for us, I think it's just really important to know what we are looking at, what we might need to look at in order to know if it's been done correctly or not. I mean, like I said, if those kind of factors, what do we need to see to know if this are these things justified? Has the researchers properly explained themselves? And then I think what you've given us is a pretty good layman's explanation of how to apply that and all that. No.
Great.
Yeah, good.
Excellent. Well, thank you everyone for attending our first CTN CAC webinar. I'll solicit some feedback later and see how it all went. Hopefully it went well. Enjoy the rest of your day.
Thank you.
Thank you all.